Hello, everyone, and welcome to the Paper Dialogue, one of our annual events held by the Economic Studies Division of Canopy from the Faculty of Economics and Business, University of Indonesia. I'm Ariela Sasi.
And I'm Gopas Theophilus, and we're both economics undergraduate students and part of the staff of the Economic Studies Division of Canopy, an economic student association from the University of Indonesia.
We will be hosting this very first paper dialogue, a spin-off from the usual book dialogue that we have done for the past few years.
This paper dialogue is a discourse that focuses on dissecting incredible academic papers. This will be done by inviting renowned writers, researchers, or policymakers who have contributed to a recent outstanding output on economics.
Because of the COVID-19 pandemic, the paper dialogue has changed its interactive format into a podcast. This format has been chosen due to its capability to reach broader audiences during the period. Even though most of the world has reverted back to its pre-pandemic way of life, we found a new use of this podcast format. It enables us to discuss with renowned economists outside of Indonesia.
In this paper dialogue, we will specifically discuss an academic paper titled The Challenges of Universal Health Insurance in Developing Countries, Experimental Evidence from Indonesia's National Health Insurance. This paper, co-authored by Professor Benjamin Olken, Abhijit Banerjee, Amy Finkelstein, Rema Hana, Ariana Ornagi, and Sudarno Sumarto, was published in the American Economic Review, one of the oldest and most respected scholarly journals in the profession of economics.
As it was written in the paper's abstract, this paper has findings which underscore how weak administrative capacity can create important challenges in developing countries for achieving widespread coverage of national health insurance.
This paper specifically focuses on Indonesia's national health insurance system, from barriers to enrollment, weak administrative state capacity, and inaccuracies in the state's civil registries. There are a multitude of problems that decrease the effectiveness of Indonesia's national health insurance system. From this paper, we are given specific insight on how Indonesia and other developing countries can design policies to better its national health insurance system.
And now our speaker for this podcast is one of the co-authors of this paper, Professor Benjamin Olken.
He's currently the Jane Berkowitz Carlton and Dennis William Carlton Professor of Microeconomics in the Massachusetts Institute of Technology and the institution's director of Abdul Latif Jamil Poverty Action Lab. Along those lines, he is also an editor of the American Economic Journal in Applied Economics and the co-director of the NBER Development Economics Program.
Thank you for taking the time to talk with us, Professor Olken. How are you today?
Very good, thank you. It's my pleasure to talk with you about this paper.
That's really good to hear, Professor Olken.
Before we start, would you like to tell us what's the backstory, perspective, and also your specific role that you had behind this research paper?
Sure, I'm happy to tell you a bit about the backstory. So the backstory of this project was in 2013, actually, we had held a conference in Jakarta in which we were trying to identify kind of what were some of the really important questions that were facing the government of Indonesia at the time, and how we at JPAL could think about assisting the government in answering some of those questions. And kind of one of the key takeaways from that discussion was that Indonesia had just recently passed sort of its social protection law, which has sort of established the BPJS Kesehatan and sort of had laid the framework for sort of moving towards universal health insurance. And from the beginning, I think that the policymakers understood that the biggest challenge in BPJS Kesehatan or in JKN, Jaminan Kesehatan Nasional, was going to be the informal non-poor sector. So just to step back for a second, the way that Indonesia has broken up sort of health insurance coverage is in three different groups. There's the people who are formal employees in the formal sector, right? So these people basically are covered through JKN, but the coverage for that comes through their payroll taxes that are taken out, held by their firms from the paycheck. So that's pretty straightforward. If you're in a formal sector, you pay taxes. They sort of withhold the taxes for health insurance, and you get coverage that way. For the poor, who were identified through in various ways, the government said, look, these households are not wealthy enough or not able enough to pay premiums themselves, so they should be covered directly through the state budget. So that's also kind of straightforward in some sense. I mean, you have to pay for it, but of course their coverage is covered. What that leaves is the informal non-poor, right? Or people who are not in that poor category, but not in the formal sector. And there, the government said, well, we'd like those people to pay premiums. And that actually makes, for health insurance, and actually that makes sense, because if you didn't have them pay premiums, then you would have a wedge between the formal sector and the informal sector. You'd sort of be making it like a reason for people to be informal. So you don't want to have that. You want them to pay something. But the challenge is you need to sort of convince people to pay, right? You can't withhold it directly from their paycheck. You need to convince them to pay. And from the beginning, I think the government recognized that this sector, and it was referred to as JKN Mandiri, I believe, how JKN sort of puts forward that sector. I think the government recognized that that was going to be a big challenge. And in particular, not only is the challenge sort of getting enrollment high enough in JKN Mandiri, but there's also a problem of adverse selection. And the economic issue is that basically the issue is, if people are free to enroll if they want to, or if there's sort of weak enforcement of the mandate, then who's going to enroll? It's going to be the people who are sick, right? People who say, oh, I really know I need health insurance coverage, I'm really sick, or I have some chronic condition or whatever. Those are the people who are going to want to pay the premium. And those are and people who are not sick are not. And that is, there's a long history of sort of economics studying of this question. And we know that sort of in insurance markets, if people can decide whether to buy the insurance or not, you have this problem that basically that, for any given price or any given premium that's charged, the ones who are going to make the rational economic decision to enroll are the ones for whom the expected benefits are going to be greater than the expected costs. And those are the people who are going to be sicker and sicker. And so that happened in JKN Mandiri, where basically initially, the people who were sort of enrolling were the ones who were really sick, and that meant that the ratio of claims of how much the government was paying out for this sector was much higher than the ratio of much higher than premiums that were coming in. So that's kind of all about backstory. So basically, this is all sort of, I think people understood, policymakers understood from the very beginning that this was going to be a challenge, and it was indeed a challenge. And so the question that we were sort of, asked to sort of help with was, were there ways of increasing enrollment in JKN Mandiri, and sort of what were the best approaches to doing that? So that was sort of the backstory and why we were asked to get involved and work with JKN to sort of see what approaches could make sense there. So that may be a longer answer than you expected. That's a bit of the backstory here.
It was a very interesting process and answer, Professor Olken. And after we read your paper, and perhaps you have already mentioned it, you gave us an overview of the Indonesian healthcare system and its current public health insurance policy. Is that right, Mr. Olken?
Yeah, I mean, basically, a reasonable overview, exactly, yes.
Perhaps you could elaborate more on that, Mr. Olken. We don't have any...
Yeah, well, I think that I think that sort of the framing of just to step back for, I think that the other thing I'll just sort of say is that I think that, stepping back even a little bit further, there are a couple of different approaches that a country could take in terms of providing healthcare. One approach, by the way, is you can do nothing. It's just sort of say it's up to individual people. I think that most countries don't want to do that, because we recognize that sort of health is really a fundamental kind of human need and a real challenge, and we'd like to do something to sort of assist people and not just sort of leave people on their own mercy. And also, we understand that health is very risky, and so there's a reason that people want health insurance to sort of help sort of smooth those risks. But we know that private insurance markets don't necessarily work very well for a variety of reasons, and so often, governments often get involved to sort of help people manage those risks. The government, there's a bunch of different approaches that different countries have taken to this problem. One approach, which if you think about it, sort of was the approach in Indonesia prior to this, was to say, look, we're going to have a public system where we're going to provide basic care at pretty low prices. So say for through Puskesmas, for example, or other kind of government facilities. And people are going to get basic care, and if they need to go to the hospital, it's going to be expensive, and that's going to be kind of a risk. But even that's going to be heavily subsidized because they're sort of through the government sector. I think that with JKN, they sort of wanted to say, well, we want to sort of encompass kind of a wider variety of providers and include the public, have the sort of primary care again for the system, but allow you to have different kinds of secondary care systems. But one approach is basically just provide the care directly. A second approach is to have the government become essentially a single payer for everybody, right? And rather than sort of have this complicated sort of three-part system that I described before, another approach would be to say, we're just going to give everybody JKN and the government's going to pay through it to the state budget. That has the disadvantage that it's a lot more expensive. So basically, you then, instead of just having to cover the premium essentially for the poor, you got to cover the premium for everybody. But that's another approach that you could have taken, that other countries could take, that some countries have taken. But that, as I said, that has a much higher has much higher sort of budgetary needs, right? And so if you don't have to do that, you might not want to do that. And so the third option is kind of the one that Indonesia took, which is sort of this hybrid option, where potentially they're basically covering the poor through the state budget, collecting taxes for the sort of informal non-poor, and then trying to get for the formal non-poor, and then trying to get the informal non-poor. So those are sort of other options that you sort of could have taken, and different countries have sort of taken those different strategies. But I certainly think it's what Indonesia is trying to do is very reasonable. The real challenge there is, what do you do with this middle tier, this informal non-poor tier, and how do you get them to sort of pay is sort of the real challenge.
Great. That was really nice knowing your view on this, Professor Olken. There's going to be more questions elaborating on how a country will handle their healthcare system. And regarding that, perhaps could you tell us more on how the current economic condition of a country, and specifically in Indonesia, affect the system, effectiveness, and participation of its national health insurance program?
Sure. There's a couple things. I think that the one key thing to think about is as countries become richer in terms of their per capita GDP, one thing that tends to happen is that the share of people who are kind of formal sector employees tends to go up. Okay, so it's actually been very nicely documented in other contexts that basically, and this is true both if you look across countries today, sort of countries with higher versus lower levels of GDP per capita. Also, if you look even say at countries that have high GDP per capita now, but look kind of backwards in time historically, it's a pretty robust pattern that basically one thing that happens as countries become richer is that you get more people who are employees, and particularly employees in kind of large formal firms. So the country's level of development affects the share of people who are in the formal non-poor group, right? So if you think about the different groups, that's kind of a level of development issue. So if you compare, say, the fraction of people in the United States who are in that category, formal sector employees, right, with the fraction of people who are in Indonesia in that category, you're going to find a much larger fraction of people in the US or in Europe or Japan or wherever who are in that category of formal non-poor than in a place like Indonesia. In a middle-income country like Indonesia, you're going to have some people in that category, but you're going to have a much bigger chunk in kind of the informal non-poor category. So that's the first way in which sort of the level of development kind of affects this question. The second way is that as countries become richer, their tax capacity tends to increase. So not just in terms of the amount of tax, but as a share of GDP. So countries become better able to tax as they become more formalized, as they become richer and typically become more formalized as a share of GDP. So that's important for a couple of reasons. Number one, if you're really poor, so if your country is a lot lower levels of income per capita than Indonesia, so if you think of some countries like, I don't know, pick your example, but countries with much lower levels of GDP per capita, they don't have the resources, they don't have the budgetary room to basically do any of this, essentially, without foreign assistance. So the fact that Indonesia has become a middle-income country is sort of what's making all this possible at some level in terms of budgetary space. So the On the other hand, as you become kind of even higher levels of GDP per capita, you have more fiscal room and you have more options available to you. So in some sense, I also think that sort of where Indonesia is in terms of the design of this kind of program is related to the overall macroeconomic condition of the country. So it's Indonesia has really grown a lot, even over the past 10 or 15 years in terms of income per capita, and therefore has now the fiscal space and tax, ability to tax whatever, and so that has the fiscal space to be able to start doing some of these things and providing this kind of important social insurance, but it's not at the level of income per capita at like the U.S., for example, and as a result, that group that we're talking about, the informal non-poor group, is much larger. The other thing which is I think relevant is and I think we're going to talk about this soon, I think, is this question of the individual mandate. And one of the things, if you think about these different kinds of programs, one way you can combat adverse selection is you can basically just require people to buy insurance, right? So you can say it's not a choice, it's mandatory. The problem is, you have to be able to, there has to be a consequence if you don't do it, right? So a mandate where I say you have to do it, like, if you don't do it, then what? Well, so when other countries have tried this, one of the big things you can do is you can impose a tax penalty, right? You can say if you don't buy the insurance, then you're going to pay some tax. Well, this gets back to the same problem, again, with the level related to this overall issue of kind of a level of income per capita. It also tends to be the case, and this is not just in Indonesia, but around the world, that countries essentially, where they set the personal income tax. So not everybody pays income tax. Most people are exempt from income tax because their income falls below the threshold above which you start paying income tax. That's related to the same point I made before with the employee share. Most countries, it turns out, basically, it's very hard to tax the people in the informal sector. It's very hard to tax people who are self-employed because the government doesn't know how much you earned. People who are employees, the government are much easier to tax because the employer can tell the government how much they paid you, and that's a way for the government to figure that out. So, at a very broad level, many countries basically set the threshold where they decide where to tax people at a point of sort of related to sort of, to basically capture most of the people who are employees and not capture most of the people who are not employees, roughly speaking. What does that mean? It means that most of those same people that were interested in the informal not poor probably aren't paying income tax either because their income is below that sort of income tax threshold. So that creates a problem because it's very hard to create a mandate and sort of enforce it. Like, what are you going to do to people, right? If you can't tax them, kind of what consequence do you have? And so what you end up being left with is sort of a mandate that doesn't really have a lot of force. It's like, you say like you have to do it, but if you don't, then what? And so I think that sort of that's another part of the challenge that Indonesia is facing, that I think is I think a challenge that's I think related to sort of the just how do you solve these problems at a country at this level of development. I don't think it's an Indonesia specific problem. I think it's pretty generic to countries at the sort of similar levels of income per capita trying to solve these problems.
That was an interesting and very insightful take, Professor Olken. So if I were to summarize, there's a pattern that as countries become richer, their share of formal workers and tax capacity will increase, which gives the government the budget to cover the healthcare system. That's the general idea. Regarding that, perhaps could you elaborate more on Indonesia's individual mandate that you have mentioned on its national health insurance plan? So Indonesia has created a contributory health insurance system with an individual mandate, which is a requirement by law for Indonesian citizens to take part in its national health insurance plan. However, as what you have said, its mandate is currently toothless, which means that there are virtually no consequences in abstaining from it. This basically created low program enrollment and adverse selection in Indonesia's national health insurance. Because of that, Can you elaborate more on the benefits and drawbacks of Indonesia's individual mandate? And is it actually necessary in Indonesia's national health insurance program? Do you think that with no individual mandate, it will cause a drastic effect on the government's national spending on its national health insurance?
Great question. So let me also just say that we did this research we did this study a few years ago. So it may be the case that there have been policy changes since we did the study that I'm not aware of. So I just wanted to sort of put that caveat out there. It's certainly possible that JKN has made some changes that I'm not aware of since then. But in general, yeah, it's a good question. I think that we don't really know the answer to your question, I would say, in the following sense. So, there's a question of there are some people, so it's certainly not the case that every single person is following this mandate, right? We know that, right? Because enrollment is not 100%. So I think that's clear, right? And certainly if you were to increase penalties somehow, if you were to find a way to do that was politically feasible, that would probably increase enrollment. It might have other consequences, but it would probably increase enrollment. What I don't think we know the answer to is whether or not if we got rid of the mandate, it would be even lower. And it may be that there are some people out there who are just law-abiding people who basically, if the government says you have to do this, we'll do it. And even if there isn't a consequence, I think, so let me give you an example. So, in the town that I live in the United States, there are, if you park in certain places, you have to pay a parking meter, right? You have to pay, put some coins in the meter to pay for parking. And if you don't, they come and give you a ticket. They give you a fine, okay? And the fine is not that big, actually. Yeah, at least in my, at least in my town. And in fact, there are places where, to park in a parking garage, might be in expectation more expensive than risking it on the street, not paying for parking, because they don't always ticket you, right? The police don't always come along, maybe they don't see your car. So if you did the rational expected value calculation of saying, like, should I park on the street, risk getting a ticket, or should I park in the parking garage? Sometimes it might work out that actually it's better just rational calculation to park on the street and risk getting a ticket. But I think most people don't do that, because I think most people view getting a parking ticket, getting a fine, as like, oh, like I violated some law, some rule, I did something wrong. And so I think there's an additional kind of utility cost associated with sort of like it's not just kind of the like dollars and cents calculation. The fact that one of them is like, yes, I pay in a parking garage, like I paid to do that kind of, that's a legitimate, normal economic transaction. Whereas the fine, I broke a rule, I broke the law, and I got like fined for it. That second one, I think people don't think about those things exactly the same. So what's the analogy there? The analogy is, by saying it's a mandate, even if it isn't really enforced, there are some people, and you can think about, you don't have to answer on a podcast, but you can think about yourself, whether or not, you would feel differently if the government said, like, this is the law, and if you break it, you're violating the law, as opposed to, not saying that. So it wouldn't surprise me if a mandate, a mandate with no enforcement is not very strong, but it may be stronger than nothing. And so I don't know any good, there may be evidence in this question. I don't know of any evidence in this question. But it wouldn't shock me if just telling people at least has an effect for some people, and maybe it helps a bit. The other thing is it also may assist the government in getting enrollment in other ways. For example, imagine you go to the hospital, right? Then the hospital can say, oh, by the way, like JKN is like, budgeted, like it's like mandatory. You have to do it. You want it, like there are different, that the fact that it's a mandate may create opportunities for people in the healthcare sector to sort of increase enrollment by saying, like, if you want to come in and get served, you have to, like, sign up for JKN first. because it's mandatory. So even that may also be another way of where it sort of has like positive spillovers. That's a long answer. It's a long way of saying I don't know, but I suspect it's different. I suspect even a mandate with no penalties is probably not the same as not is probably different than not having a mandate whatsoever. That's my best guess.
Thank you so much for your really insightful answer, Mr. Olken. That was still really an interesting take for us to hear.
Yeah, that's still an issue that the government will have to work on. And if you don't mind, Professor Olken, there are some questions that I've been waiting to ask. I would like
Sure,
to
go
know
ahead.
your okay. I would like to know your perspective on this situation. So, as you mentioned before, some countries such as Thailand have created a single-payer-like system, right? Funded entirely out of tax revenues and supplemented by small co-pays. While Indonesia have sought to create a contributory system with an individual mandate that you mentioned before to reduce the financial burden on the government. Well, in this system, the very poor are subsidized by tax revenues and everyone else is required to pay a premium, like you've mentioned before, and collected through a payroll tax for formal sector workers and also collected directly from individuals for everyone else. Now, can you help us elaborate on how a contributory system specifically reduces the financial burden on the Indonesian government? And
Sure.
if we use a single payer system, do you think it'll work better for Indonesia's healthcare? That's like something we have to think about.
Yeah. So I think that okay, so I think that the question is sort of let me try to formulate an answer.
Oh, it's okay.
There's a couple of different types of ways you could think about a single payer system, and they do matter a bit. So in one type of single payer system, you could basically say we're going to give up on trying to collect premium from the informal non-poor, but otherwise, and just cover them like we cover the JKN for the poor, and but keep the payroll tax there. The challenge with that system is, number one, it would have a big fiscal consequence, not just because you would lose the revenue from the informal non-poor from those premiums, but also because you would be covering everybody, right? So there's some people now who are not covered by JKN who are just paying their own way if they get sick. You would, of course, they would get value from that insurance, but the government would cover all those people too. So I think it's not quite, the fiscal difference is not just like, oh, we wouldn't get the revenue, but also the costs would go way up, right? So I think that the fiscal difference, you have to think about both those things. That's the first point. Second thing is, if you were to do a fiscal, if you were to move to a single payer system, sorry, if you were to just do that scheme I just discussed, you also have the second problem, which is you would create a wedge between the informal sector and the formal sector. So if you basically say we're going to keep taxing the formal sector through a payroll tax, but you basically give the health insurance to the informal sector for free, you're creating an even bigger incentive to be informal, right? And that's the last thing the government wants. We want people to be more formal because we can collect tax from them in a variety of places. We can make sure they have other worker protections. We can make sure that they're sort of like following a whole bunch of other regulations. Like the government in general wants people to be in the formal sector. So you wouldn't necessarily want to do that. So if you were to go to a single payer system, you might want to think about financing it not just out of a payroll tax like you're doing now, but more generally through other sources of government budget. So you want to think about the other sources of tax the government has, like value-added tax, corporate income tax, all those things. So I think that like it's not quite the same. So I guess the bottom line is I don't think you should say just because the premiums that are paid are not enormous doesn't mean that sort of it would be a trivial thing to switch to a single payer system. I think not at all.
Okay. That's an interesting take actually, and it answers my question. So in this case, Indonesia fits more on the contributory system.
Well, that's
Thank
what
you.
it's doing right now. I mean, you could, as I said, like Indonesia could have considered a general single payer system, but then it would need to take on board covering premiums for everybody, and that would be very expensive. And so you would probably need to raise other types of taxes in order to cover that.
Yeah, and the goal is for Indonesia to, well, cut down their spending actually. Okay, thank you. That was really clear and fascinating. Now I'll ask the next question. Now,
Well, sorry, let me say it's not obvious the goal is to cut down on spending. I think that like the country can decide what goals it wants. I'm just saying that there are pros and cons. That if you went to a single payer system, you would have the benefit of covering everybody and not having kind of these gaps in coverage. But the flip side is you need to raise taxes in order to do it. So it's kind of and raising taxes has other consequences. It distorts the economy in other ways. So it's kind of there are pros and cons. I'm not saying there's a single right answer. I'm just saying that that's kind of a decision that the Indonesian people and the government would need to decide on.
Okay, thank you. That was really clear and fascinating, actually. Now I'll ask the next question. With rising commodity prices and also unstable macroeconomic conditions and the global economic recovery from the COVID-19 pandemic, are there any other financial implications regarding the national health insurance subsidies toward household and the government in Indonesia?
So what do you mean? Sorry, Ariella, can you clarify your question a little bit?
Oh, I'm sorry. So I'll repeat. With rising commodity prices and unstable macroeconomic conditions, and also during a global economic recovery from the pandemic, are there any other financial implications regarding the national health insurance subsidies toward household and the government in Indonesia? Basically, the current economy that's a bit in chaos, and how it affects the national health insurance subsidies toward household and the government in Indonesia.
Yeah, well, a couple things to think about. The first is obviously, the source of a lot of the current crisis is ultimately comes back to a health crisis, which is the pandemic. So, you wouldn't necessarily want to be cutting back people's access to healthcare exactly at a time when you're facing a health crisis. So that's sort of one thing to think about is that there is sort of just because the initial wave of the crisis has gone down doesn't mean that we're necessarily totally out of it either. And so I think making sure that people are protected in case there are other sort of types of rebounds or whatever is something to think about. The second thing is I think that the biggest challenges right now to the state budget, biggest challenges right now for the government are probably coming more from other challenges about commodity prices, the fuel price and sort of the fuel subsidy, things, energy subsidies. I think that's probably where the biggest shock change is. I think actually, I don't know the answer to this question, and I would encourage, because I haven't looked at the budget numbers, and I would encourage you to go do so. But I suspect you would find that the biggest changes in the government budget are not coming from changes in health insurance, either spending or receivables, but are really coming from what's going on energy prices and commodity prices, both on the revenue side and the expenditure side. And I think that actually, from a macroeconomic perspective, I think probably where, if you were the Minister of Finance, what you'd be worried about is kind of probably much more sort of the costs and benefits of those types of shocks rather than through health insurance, my suspicion.
All right, thank you, Professor Olken. So far, this has been a really insightful discussion on Indonesia's national health insurance. And maybe we could discuss something that just recently happened to Indonesia's healthcare system. So basically, Indonesia has just abolished its coverage classes and has increased its average premium on its national healthcare insurance. So instead of 3 classes differentiated by its premium and quality of healthcare, there will exist a universal quality of healthcare for all insured people. What are your thoughts about this?
Well, so actually, let me say, as I said, I haven't followed these latest developments as much, so I don't know the details of this. Can you tell me a little bit more about sort of what the new policy is? Is it equivalent to the old class 3 or class 2, or what's the?
Yeah, it is about class 1 and class 2 and class 3. So basically,
the old one had 3 classes, and what's the new? How does the new one work?
The new one basically abolishes the classes. So there will exist the universal quality of healthcare for every insured people. That's how it works.
And which quality class does it correspond to?
They haven't specified actually, but basically, basically there will exist universal quality of healthcare, and this will actually continue to our next question, because the next question is, what advice do you have for the Indonesian government to ensure an equal high quality service of its healthcare to all citizens while maintaining this policy?
So, let me just say, it's not, I think there are pros and cons of this kind of policy, right? The pro is the government may want to have a policy which basically says we're going to treat everyone equally and you can't buy better quality healthcare. The con is the downside of this kind of policy is, we might have a view that we want to make sure that everyone's health is sort of treated equally, but the sort of amenities that you get to have while you're having that healthcare might be less important to be equal. For example, we might say, look, if you have cancer, we want to make sure everyone is treated for cancer. But, everyone doesn't need to be treated for cancer with a private room with air conditioning. We might feel like it's okay if you get treated for cancer, as long as your health is sort of taken care of, whether you're in sort of the equivalent of, a more basic facility in terms of the, with typical food or whatever, or a fancy facility with sort of like air conditioning and a private room and nice quality food, might be something that we don't necessarily think is as important. And if that's the case, the government might be able to raise a lot more rev, but some other people, individuals, might care about that. People who are richer might say, well, you know what, actually, I prefer the private room or whatever. I'm going to pay a lot for that. And the government might be able to use the fact that some people are willing to pay for those higher quality rooms to raise a lot of revenue they could use to subsidize the people who sort of need the basic care or not. So I think that there's a question about whether the differences in classes of, if the differences in classes of care, which my understanding were not about sort of the basic health coverage you're getting, but more about sort of what the overall experience was like. I think there's a reasonable debate as to whether or not everyone should have, whether people should be able to sort of pay for that kind of better quality of care, whether the government could use that as a way of generating revenue to help sort of cover sort of more of the people who really just need the basic care. So I think that the question I would want to think about if I was the government is sort of what are the pros and cons there? What are the differences in terms of the quality of service, and is it really a health difference? In which case, there's maybe a different normative case for making sure everyone's the same thing, or it's sort of these like extra perks. In which case, maybe we don't, necessarily want to guarantee everyone the same thing. In the same way, for example, that people have different quality of houses, right? And the government hasn't passed a law that everyone needs to live in the exact same quality house. We understand that. In this world, there's some inequality, and people who have more resources can have a nicer quality house and are willing to pay for that. And if part of those differences in healthcare is sort of equivalent to that, like you get a nicer quality room while you're getting the same healthcare, maybe, and the government can raise a lot of money for that to help cover sort of more people. That's a trade-off the government want to think about.
Okay, thank you for that, Saraik. So there's pros and cons that the government should continue to consider. Either is equality and priorities. So am I correct?
Yeah, I guess the question I would think about is, I don't actually know what the rationale for this was, but I think the question is, is there a way? Another way to think about it is, are there aspects of if there are aspects of healthcare that look a lot more like other things we let the private market allocate, are those things that the government might want to allow some heterogeneity in? I think and could it use that as a way of generating a lot more revenue that it could use to sort of cover the people who need sort of the basic care and sort of extend coverage to everybody? That's something to think about.
All right, it is then something that we should think about. Thank you, Professor Olken. Also, maybe we should move to the next question. I would also like to ask if the other barriers preventing universal health coverage, such as the misperception of the value of the health insurance itself and the quality of the healthcare, are still significantly preventing Indonesia in ensuring accessible healthcare. This kind of correlates with the previous question, but
Yeah, it's a good question. You know, one thing we did try to look at in our paper was whether or not giving people information about sort of what health insurance covers and the value of coverage and kind of the risks of being uninsured, whether that would make a difference. And we found just providing that kind of information made no difference whatsoever in terms of enrollment decisions. One thing we did find was so on the one hand, just telling people stuff doesn't matter. We did find that there's a bit of an experience effect. So people who have experience with the health insurance do tend to be more likely to continue it later. Not 100%. But people on average, some fraction of people, if they have the insurance for a period of time, decide, oh, actually, this is pretty good. And actually, I kind of really value this and I want to keep this in the future. So that does suggest that sort of as people get more experience with health insurance, that may sort of increase demand for it altogether. The other thing I'll say is that one thing we found was that sort of making the enrollment process easier could actually also make a difference. So we found a large number of people who were, if we said, here's the thing, here's insurance, would you like our help signing up for it? They said, sure. If we can do it at home, like we'll bring a laptop to your house and help walk you through the enrollment process. They said, great, let's do it. But then they had problems sort of getting actually enrolled due to sort of, challenges in the administrative data or whatever, and they didn't succeed in getting enrolled. So I think it looked like there was a big gap between the people who at least stated they were willing to have coverage and the ones who actually did due to sort of those enrollment barriers. And so anything the government can do to make it easier for people to sign up for health insurance is likely to be effective.
Fascinating, actually. Perhaps, Professor Olken, this actually also correlates with the previous question. Can you elaborate any methods you can propose to increase enrollment and reduce adverse selection in Indonesia's national health insurance program? This actually is the main topic, right, in your paper. But we want to hear it. We want to hear it from yourself on how would you propose to increase the enrollment itself.
Sure. So we found a couple of things that were successful. One was temporary price reductions. So basically, almost like a trial period, right? That actually we found was successful in actually increasing enrollment a lot because it got people into the system, they got experience with it. So actually we found that was actually a policy that could actually increase enrollment substantially. And not just enrollment, but actually reduce adverse selection by getting healthier people into the system. So actually it was a pretty good idea, something the government could try. And the second thing was we found that these hassle costs or administrative barriers for enrollment were pretty substantial. So anything the government can do to make it easier for people to sign up, I think could really make a big difference. I think those are the two biggest things I would encourage the government to do, particularly the enrollment barriers. If there are ways of making it easier to sign up, I think the more the government can do on that, the better.
All right, thank you so much for your answer, Professor Olken. I'm gonna summarize your advice. So basically, temporary price reduction and reducing administrative barriers can help people enroll way much more than before, right?
Correct.
Okay, thank you so much, Professor Olken.
Okay, we have talked about the challenges that the Indonesian government is currently facing in ensuring universal health insurance in Indonesia. Professor Olken, do you have any final messages that you want to say to us regarding this topic?
I don't think so. I think we pretty much covered a wide variety of issues there. It's great.
Thank you very much, Professor Olken, for your time and answers today in this paper dialogue.
And with that, marks the end of this year's paper dialogue. To listen to more discussions about economic affairs, don't forget to subscribe to Canopy On Air on Spotify, YouTube, Google Podcasts, and other platforms. I'm Ariela Sasi.
And I'm Gopasio Philus, signing out from this paper dialogue. Thank you for listening.